So good morning, afternoon, evening, middle of the night, everyone, and a really warm welcome to our symposium on involving the public in data linkage research. My name's Annette Braunack-Mayer. I happen to be in Wollongong, just south of Sydney, where it is early in the evening. We have a really interesting panel of presentations to share, and we've got lots of time at the end for questions and interactions and some live polling. So the focus, as I said before, is on involving community members, citizens and the public in data linkage research, and we have a mix of presentations that are conceptual and then some examples. So I'm just going to really quickly give you a rundown on who's talking when, and then we'll go straight into our presentations. We'll run through all of them. And so if you can hold your questions until we get to the end of the session, we will tackle things together then. So Mhairi Aitken is going to begin talking about a consensus statement on principles and applications for involving the public in data linkage research. Then from her, it's over to Alison Paprica, who's going to tell us about a plain language statement, plain language communication informed by the Health Data Research Network's Canada's Public Advisory Council. Kim McGrail is talking about public deliberations on cross-sector data linkage and combining public and private sources of data. And then Felicity, Flack, and I will be talking about sharing government data with private industry. So two more conceptual presentations and then two examples, and a fair amount of time for a Q&A session at the end. So with no further introductions, I'm going to hand over to Mhairi, and Mhairi, ask you to then share your screen and off you go.
Thank you, Annette. Yes, so I am Mhairi Aitken. I'm a EFIC research fellow at the Alan Turing Institute, and I'm going to be talking this morning about an international consensus statement on public involvement in data linkage research. Apologies for the background noise, our children getting ready for school. Hopefully will be no more. Yeah, so I'm going to cover a few things in the next 10 minutes. So I'm going to talk about this international consensus statement, which was published last year. And it sets out some key principles to underpin best practice in public involvement and engagement for uses of data in health research and secondary uses of health data. So I'm going to begin by giving a bit of context as to why we felt it was necessary to develop this consensus statement, the rationale for doing that. And then I'll go on to say a little bit about how it was developed and the principles that were reached through that consensus, through the consensus process. So to begin, I'm sure it's no surprise to anybody who will be listening to this that in recent years there's been a really significant increase in interest around data ethics, and that's across a range of policy areas and a range of sectors, but particularly within health contexts. And that relates largely to issues around artificial intelligence and big data analytics. And it's in part a result of high-profile public controversies around previous data misuse or data abuse. And perhaps internationally, the most high-profile example of that would be the Cambridge Analytica Facebook scandal. And then in different countries, there have been many other more national or regional scandals around data misuse and data abuse, and particularly within health contexts. Within Europe, we've also seen the introduction of the General Data Protection Regulation, which has again increased public interest in the use and reuse of data, and perhaps increased public understanding or awareness of the value of data, and the value of data to be both used well for benefits, but also to potentially be misused or abused. So such factors have combined and resulted in increasing recognition of the need to ensure that data are used in ways which are appropriate, legitimate, and publicly acceptable. And increasingly is an interest in this idea of pursuing a social license for current and future data practices. And by social license, I mean that there can be meaningful differences between what is legally permissible and what is socially acceptable. So it's really important that we understand public values and public expectations around the ways that data will be collected and used or shared or reused, and to ensure that we align with public values and public expectations in current and future data practices. So coming out of this, in recent years, there's been growing attention and growing interest to public involvement and engagement to ensure ethical practice and to establish a social license for current and future data practices. Typically, when there have been controversies around data misuse or data abuse, particularly within health contexts, the kind of routine or typical response from policy, from institutions to these controversies has been to re-emphasize commitments to public involvement and engagement. And public involvement and engagement is often advocated as a means of restoring public trust. So restoring public trust in the ways that health data are collected and used, or restoring public trust in key institutions or key policy bodies. But often the emphasis here is very much on a focus on public trust within current institutions, or trust in how we plan to use people's data, and much less so on what it would mean for those institutions and for those practices to be trustworthy. And that's a really important difference, and it leads to different ideas of why you would engage the public, or what public engagement would look like, what the objectives of that would be. And so this has led to varied commitments and varied actions around public involvement and engagement, and led to public involvement and engagement being pursued for different rationales, through different methods, and leading to a variety of different outcomes and impacts. And so this was the reason that a few years ago now, myself and colleagues in the Far Institute of Health Informatics Research in the UK decided to develop this consensus statement to try and set out some principles to guide best practice, or to inform best practice around public involvement and engagement in this area, and to reach some kind of consensus internationally around what good public engagement looks like. So this was in 2017. Myself and colleagues in the Far Institute of Health Informatics Research ran a workshop in Manchester in the UK, and it brought together 31 international participants. So these are people who had a range of expertise around public involvement and engagement, or around research into public attitudes towards uses of health data. The participants came from policy backgrounds, academics, practitioners, and also members of public panels relating to health informatics projects. It was an international group, and in the workshop we discussed current experiences with public involvement and engagement, experiences of what was working well, as well as challenges that were faced around public involvement and engagement, and we aimed to work towards a set of principles to underpin future best practice. So the workshop took place in 2017. This is a consensus statement which was published in 2019, and the gap, those 2-year gap, is something of an indication of the iterative dialogical process that it took to reach a final consensus statement, which was developed through iterative drafts. So the key premise underpinning this consensus statement is that the public should not be characterised as a problem to be overcome, but a key part of the solution to establish socially beneficial data-intensive health research for all. Within the consensus statement, we outlined some key features of why we thought that public engagement in this area was particularly important. And we recognised that perhaps the methods of public engagement are not necessarily different from methods in other areas of health research or other areas of health policy, but there are some features of data-intensive health research that make us particularly worthy of particular special attention. First of all, public involvement and engagement can have a role in bridging the gap between data scientists and data subjects. So while in other areas of research, particularly more clinical forms of health research, researchers might be more likely to have contact with the subjects of their research, or to have more direct involvement with users and subjects of research. In research using large data sets, the data scientists or researchers are often quite far removed from the subjects of that data. And so public involvement and engagement is really important to increase understanding and awareness of the real lives to which that data relates, and to understand the potential benefits, but also the ethical issues that need to be considered. Secondly, public involvement and engagement is really important to bridge a gap between members of the public and the data about them. So while members of the public are perhaps increasingly aware that data is collected and reused in a number of contexts and for a number of purposes, they're not necessarily always very aware or sure of what that data looks like, what it is, where it's collected, and who has access to it. So again, public involvement and engagement can be really important to bridge that gap and increase understanding and awareness of what data looks like and how it's being used. Public involvement and engagement also has a really important role in establishing a social license for current and future uses of data and data practices. And that's really important where this is research using data from large populations, big data analytics, where we don't have explicit individual consent from every data subject. And so public involvement and engagement is important to assure that more broadly those practices are aligned with public values and public expectations, and to underpin a social license. So finally, the consensus statement set out a set of 8 principles to underpin future best practice in public involvement and engagement with data-intensive health research. And these principles were that public involvement and engagement should, firstly, have institutional buy-in, And this is really important to ensure that public engagement is adequately resourced, so to ensure training, financial resources, time resources, to ensure good quality public engagement. But it's also important to ensure that public engagement is able to have impacts, so that there are institutional commitments to act on the outcomes and the recommendations of public engagement, and to ensure that that can really produce impacts and realise the value that it brings. Public involvement and engagement should have clarity of purpose. That's clarity around the research that it relates to, or the institutions that it relates to, but also its own purpose and objectives, and to manage reasonable expectations of what might be the outcomes of public involvement and engagement. It should be transparent about the data intensive research that it relates to, but also transparent to its own purposes and its own objectives. It should involve two-way communication. So it shouldn't just be about awareness raising or providing information about what's currently happening, but it should involve dialogue and reciprocal communication, which involves listening as well as communicating. It should be inclusive and accessible to broad publics. And that's not just about physical accessibility, but also accessible to different viewpoints and different ideas. So we're not necessarily aiming to produce consensus, but reflecting a range of views and a range of perspectives. It should be ongoing. So as far as possible, public involvement and engagement should always be part of a programme rather than simply one-off events. And that enables it to reflect and adapt to changing circumstances and changing developments, and therefore to have more longer-term impacts. It should be designed to produce impact. So there needs to be mechanisms in place to realise the impact, and not just to produce recommendations, but actually have mechanisms in place to turn those recommendations into actions. And finally, evaluation always comes last on these lists, but of course it shouldn't just be at the end, it should be throughout at all stages. The final principle is that public involvement and engagement should be evaluated. And this is really important to build a body of evidence around good practice of public engagement and increase understanding of the value and also the methods and approaches involved in public engagement. So just to finish, as I said, public involvement and engagement is increasingly a part of the contemporary landscape of health research and healthcare innovation. But we're seeing a variety of commitments and a variety of rationales behind approaches to public involvement and engagement. There's a risk that in many cases, these commitments are enacted tokenistically or cosmetically. And so it's really important that we build on these principles and pursue best practice of public involvement and engagement, and build the evidence base around that in order to increase understanding and increase institutional commitments and institutional appreciation of the value of public engagement, to realise best practice and to underpin a social licence for data-intensive health research now and into the future. My final point, there are no quick fixes, but ethical practice requires building and maintaining relationships over time with publics as partners. And that's really important, and will be really important going forward for a social licence for future practices. So from here, I'll hand over to Alison.
Okay, thanks a lot, Mhairi, and hello, everyone. I am Alison Paprisa here from Health Data Research Network Canada, ICS, and I also have an academic appointment at the University of Toronto. And I'd like to say also, just in closing off Mhairi's presentation, that I was really so pleased to be one of the participants of your group, and I reference the key premise coming out of the consensus statement in particular all the time. It's a real North Star and guiding light. Today, I'm going to talk a little bit about plain language communication about Health Data Research Network Canada and how it's been informed by members of the public. If you'd like to know more about this, there are a few publications you can go to, and this is also the opportunity for me to very much acknowledge my collaborators, Kim McGrail, who's on the panel, and Michael Schull. And this one in International Journal of Population Data Science, Notches on the Dial, a call to action to develop plain language, really makes the point that we need to be a little bit more specific in our communications with the public to help them understand the differences between, for example, a hospital using its own data, a clinical trial with consented data, and we argue, these special cases when we use data without express consent and the need to have deep public engagement and public involvement in those cases. And the content is also presented for non-academic audiences in a couple of articles in the conversation. And I'll give my little plug that this has been a great way to literally reach thousands of people that otherwise, are not going to get the message through academic journals. So it's from this second piece in the conversation that we have this quote. There's so much emphasis on trust these days. It came up a couple of days ago in the presentations on law, ethics, and governance. But really, you can't have trust without transparency. And if you're talking about trust of members of the public, you cannot have that transparency and trust without plain language. A little bit about Health Data Research Network Canada, for those of you who may not know us well. We are a pan-Canadian network of organizations that are working together to help researchers do more and better multi-jurisdictional studies using de-identified health data. And incorporated in January 2020, Kim McGrail is our leader, our scientific director and CEO. If you're at this conference, you probably read this and you look at the icons beside it and you sort of get it at some level, that there are many organizations involved with data collection, data sharing, access to data, and we've come together as a network really to help researchers with these multi-jurisdictional studies. But if you're a member of the public, we found out, this slide doesn't have a whole lot of meaning. First of all, you're not a researcher, so it's not aimed at you. Secondly, if you look at those logos, you might at the most know 2 or maybe 3 of them. And terms like multi-jurisdictional studies and de-identified data probably don't have a lot of meaning. You may not even know that your data are being used in these research studies. So we learned that if we're going to be true to our goal of being transparent and being trustworthy, we need to have communications for members of the public, which are co-developed with members of the public. And some of the work we've done to date has involved actually our interim public advisory council. This was a group of 6 advisors who we brought together in 2018. And really their primary purpose was to help us determine the mandate, terms of reference, and how we would recruit our permanent public advisory council. But because we were also getting HDR Canada off the ground at the time, they provided some foundational advice about how to communicate with members of the public. And then really importantly, we did what we call our beta version webinar, where we created slides and we held an event, 2 events actually in French and English. And in total, we had more than 65 people come and tell us what made sense to them and what didn't make sense to them, both live and with a follow-up survey. And that was done in French and English. And importantly, we recognized that, so many people in our network, we sort of know them through the strategy for patient-oriented research. And we didn't just want to hear from the people who were already involved. So we sort of had this sort of invite a friend message in the invite. And we got many people who had no prior involvement with patient-oriented research or public engagement. The remainder of this presentation, I'm going to focus on examples of our specific HDR Canada communications and how they've been informed directly by the needs and requests of these people that we interacted with. I want to make the point that very much this is a group effort. We have a public engagement working group. We work together on these materials, and in particular, Frank Gavin, Kim McGrail, and Mhairi Long, who's the staff person who's actually led the communications. I also want to say, just before I quickly launch into these slides, I was looking at them thinking, we're at an international conference. Am I really going to present, these very simple slides? And the answer is yes, because that's the whole point, that when we think about communicating with members of the public, this is the kind of thing that's the end product. And it's really about the process and how we got to these simple slides that I think might be relevant for the broader audience here. So here we go. First point they made to us is, whoa. Before you start talking about Health Data Research Network Canada, we don't know what health data are. Tell us what you mean. And so after considerable discussion, we decided to present it this way, where we emphasize it's about the services that people receive, and we give examples that we think most people will relate to. The text at the bottom here, we emphasize that health data are routinely collected automatically every time you, in the first person, interact with the health system. The next thing we quickly found is if we wanted to be truthful about our goals, it wasn't enough to say what health data were. We had to talk about health-related data as well. And here again, there's some deliberate choices here. We use the term social determinants of health, but we pick examples that we think are relatable to people. And in the text in the bottom of the screen, we emphasize why we're doing this so that we can get a more complete picture of the health and well-being of people in the data sets. And just a few other things to note here is that we're very deliberate in saying neighborhood level income data, because part of what we heard from people is that there's a concern if they think we're working with personal level income data. The next question they were directing saying, so, okay, we get it, data is good, et cetera, but what's the problem that HDR in Canada is trying to solve? Why were you formed? And again, after much discussion and back and forth, we thought we'd present it in terms of the biggest challenge for health data research in Canada, which you can read here. We present to members of the public, is the fact that we've got these data centers which have similar but slightly different data holdings. And this results in almost all the studies we do being within a single jurisdiction. We can't make these apples to apples comparison, and framing it as a loss. We are unable, without HDR in Canada, or we're unable to learn from the different approaches that jurisdictions are taking to common health problems. Our members of the public said, okay, that's fine, but how will we benefit? And so we created this slide, emphasizing that researchers, when we have access to the data, it's easier to conduct studies on topics that matter to members of the public, such as the ones that are listed here. And we've got and more there to indicate that this is not everything that we do. So we've got that, have worked with members of the public on that. But one of the interesting finds we had along the way is there was really no substitute for some simple question and answer type framing of information. So bottom line, people said, we've read all this, but this is what I want to know. Will researchers using HDR in Canada be able to identify me? And the very clear answer, no. No, because the data we use for research don't include this identifying information. And in addition to that, assurance in terms of the agreements researchers sign. Another question that came out of our webinars, and this I think is we're talking a little bit about too, is about Indigenous peoples and their data. And this was one that was a bit of a challenge for us, because when it comes to work with Indigenous peoples, we want to make it, we worry about sort of cursory, surface level responses that might be seen as more checkbox as opposed to reflecting our commitment to this. So I really want to thank Jen Walker, who many of you will have heard a couple of nights ago, for helping us to develop this slide, which is short and to the point, but really conveys our commitment to working with Indigenous peoples and having an Indigenous-led team. And I'll add that Jen's advice went right down to the selection of this image, a nature image, as opposed to one that might be associated more specifically with First Nations, Métis, or Inuit peoples. And our final question, which honestly maybe should be the first if you really want to know what people are asking, will my health data be sold? No, your data will not be sold. And I emphasize this one here as well, because part of our challenge is that in describing this whole network of many different organizations, there are different practices. But I think that we found here a way to give people the assurance they need that despite this variation, at no point will their data be sold without being misleading in any way. So lessons learned in future work. Really, we did learn that the public is a different audience than the researchers that we were set up primarily to serve. And so our communications for the public are going to be more than plain language versions of those sentences intended for researchers. Arranging information in the form of answers to common and genuine questions that members of the public have seems to hold some promise, and that really the complexity can often stay behind the scenes. It needs to be available for transparency, but the people that we've been working with emphasize that they want succinct, understandable messages, and they'll follow up with additional detail. In terms of future work, we've now established our Public Advisory Council. We had the orientation meeting just last week, so we're going to be ramping up work there. And among other activities on the Public Advisory Council, we have a plan to work with members of the public to co-develop very simple language related to how data are used and by whom. And that's something that's covered in the article in the conversation. And also we'll be looking for collaborators on if people are interested. And with that, I'll conclude my presentation and turn it over to Kim.
Great, thank you. And like Alison, I am really pleased to have been involved in the session that Mhairi described in the consensus statement. Can I just make sure that the slides are showing as they should be? Yeah, okay, good, thank you. So I'm Kim McGrail, and I'm at the University of British Columbia, and as Alison said, also Scientific Director of Health Data Research Network Canada and Population Data BC. So, and really, the start of my journey really was just a bit before the consensus statement that Mhairi described, really recognizing that researchers have a whole lot of ambitions related to linked data, and that we really need to involve the public in thinking through where we hit the edges of what's acceptable, accepting that difference between what's legally allowable and what really is normatively acceptable to the public. So the deliberation I'm going to be talking about today is about cross-sector data linkage, but really concentrating on electronic medical record data and then combining public and private sources of data, because we felt that these were areas that sort of started to touch that edge of the what we know is acceptable versus the ambitions that researchers are expressing. So before I go further, I have no conflicts and nothing to declare, but I do really want to make sure I recognize the amazing contributions of my collaborators on this project and the funding from the Canadian Institutes for Health Research. So I'm talking about not a consensus statement development like what Mhairi described, or the individual committee work like Alison's describing, and then there's juries that are going to be the subject of Annette and Felicity's conversations. This is yet again a different form of deliberation or public involvement, and it's methods that have been developed by the people noted here, Kieran O'Doherty and Mike Burgess, and they've been implemented in many different deliberations in several different countries. The basis of this deliberation method is that we spend 4 full days with people over 2 different weekends. So this is a small group, 25 to 30 people usually. You bring them together, give them some background material and some education, and then invite them to discuss with each other using both passion and reason. So the idea here is not that we're trying to get a large group of public to come to some kind of consensus, but instead we're trying to find ways of crafting rules around things, in this case about data use, that we can all live with, despite the fact that we know that there's going to be diversity and not necessarily always full agreement among people about what matters most and what's most concerning. I will emphasize that this is quite different from a focus group in the sense that the messages that come from these groups are crafted directly by the participants, but also that we're not providing background information or education with the intent of making people into mini experts, but instead just giving them enough so that they can have an informed discussion and debate amongst themselves. So we do recruit 25 to 30 demographically stratified participants. And what I mean by that is we actually are not looking for a representative sample. We're looking for maximizing diversity of perspective and experience. So we want to make sure that we have younger people included. We want to make sure that we have people included who live in rural areas of the province, who are really going to come. And I emphasize, we pick people expecting that they have diverse views, but we don't pick them for their diverse views. We pick them based on demographic characteristics. We, in preparation for these sessions, develop an information booklet and develop deliberation questions. As I said, the topics here really revolved around electronic medical record data linkage with other data sets, and then combining the private and public sources. We recruit speakers, and then everything else is essentially like planning a large party for 30 people over 2 weekends. So it's a lot of details. So the deliberation itself, we have access to this wonderful room that has this large horseshoe-shaped table, so people have an ability to see each other as they're getting to know each other and speaking. So obviously we did this a year ago, so we did this not in 2020, otherwise it wouldn't look like this. The speakers that we had at this particular deliberation included an ethics and legal expert, so somebody who could provide the expectations around the legal framework and ethics expectations. Somebody who's a privacy advocate, specifically somebody who is interested and works in the area of surveillance society and with marginalized populations. We had a researcher who's focused on the use of electronic medical records data, who talked about the benefits of using those data. And then somebody from the CEO of a private sector industry association to talk about the research needs and opportunities in that area. So the speakers are provide this background, the deliberation. The participants then are able to ask them questions before they then work in small and large groups and eventually come to recommendations, which they then feed directly to a panel of policy receptors, because all of this is done in conjunction with people who actually can help make policies in these areas. So there's lots more on methods, but I really want to spend the rest of the time going through the set of recommendations that the public gave to us around this. So there are 4 areas that I'm going to go through. There's 17 recommendations in total. The slides are going to be just a little bit more wordy than I would usually use, but the reason for that is that these are the words that were crafted and voted on and accepted by participants. And then the last thing I'll say before going through these is that the fact that I'm showing them here doesn't mean that everybody voted for or agreed with these statements, but we do have a voting process. And then some of the discussion is around whether you agree, disagree, or abstain. And those reasons themselves are really, really important in informing policymakers, because it gives some background and the rationale for the creation of these recommendations, but also helps the policymakers see where the level of agreement starts to dissipate a bit. So in this broad one of 4 themes of balancing risk and benefit when linking data, this is obviously I synthesize these into themes, but otherwise the words are the participants. So first, it's important that protections do not unduly restrict research using data. So there's this fundamental acceptance of research that I think all of us who work in this area recognize is pretty universal. Combining public and private data is acceptable if due consideration is given to mitigation of discrimination. This is a theme you'll see more than once here, that there is a real attention to smaller and potentially more marginalized communities. It's acceptable to combine public and private data when the research has more potential for public benefit than risk. And again, I think this is consistent with international literature, that people understand there may be risk, but that the public benefit absolutely has to be there. Okay, so then we go on to this expected protections area. And here I use the little eyes because this is really comes down to oversight, the kinds of things that the public expects as oversight. So first, the use of the data must be peer reviewed and appropriate for the research, taking into consideration privacy issues. So in other words, a very specific focus on what data are you using for your research. The research proposal itself involving the use of data must be peer reviewed. So there's this attention overall to the scientific merit of a proposed use of data. They felt that it was acceptable to combine public and private data when the data linkage is done by a trusted third party. So not the researchers seeing the individual level data, but a party that's separate from the research process. The independent oversight review committees, which they thought should exist, should have authority to hold researchers accountable for the appropriate use of data and impose consequences. And they were really quite focused on the latter part of this with the consequences. The independent review committee being under government oversight. So, and this one was interesting because it did represent a bit of a split, and it came down to whether government really should be the ultimate authority in all of this area or something else was needed. And there was no resolution to that in the end. And that's something that everybody agreed with. So then there's a third area of authorization. So who gets to say that the things are met? So this is one of the things that they said about authorization is that we should have informed consent when we're talking about genetic data. This was clearly a data type that brought out different considerations and concerns. It's acceptable to use all medical data, including EMR data, without consent, provided that there's an option to opt out. So this was not a blanket okay to use because of the recognition of the specific additional detailed information that can be in EMRs, but what they discussed was this balance of research really benefiting from broad participation, the broadest possible. Research that combines public and private data should be authorized by independent multidisciplinary committees that have a range of expertise. So there needed to be a multi-stakeholder type of and multidisciplinary oversight for this. And then there was this additional comment that data from small communities should be considered for informed consent due to higher risk of re-identification. This subject came up many times in this deliberation, just with the additional different concerns of people who live in small communities where the identification or a data breach may have particular implications and consequences for feeling the potential for discrimination. There was a final theme about ongoing public involvement, because we did have a specific question about how should we talk with the public about this in an ongoing way. And the recommendation here is that there should be an ongoing citizen advisory. People really felt, I would say that they felt honored to have been able to participate in something like this that had the clear attention of policymakers, and that we should pay attention to diversity if we are going to go forward and having a public involvement. You can see here that they were not talking about a specific kind of diversity, but actually a diverse set of diversity characteristics. That we should recruit for an ongoing advisory seeking seeking this as described above. So in other words, they were really endorsing the fact that we should have this. It's important to have an ongoing public advisory that meets face-to-face, because they recognize the value of spending so much time together, getting to know each other a little bit, as well as having these in-depth conversations. However, there should be an option to meet through other communications technologies as available. So they didn't want that to be a barrier to diverse participation, but they recognize the value of being together in person. And finally, here, an ongoing public advisory should meet at least a minimum of twice a year as needed. And this really was a matter of, if you're going to go to the effort of putting this together and training people up, you probably should have a specific set of important things that you want to discuss with them. And if you don't think you have that, then essentially the impression I had was, don't waste our time. Oh, sorry. And then we should have membership terms of 2 years with 50% turnover. And this is just to represent a lot of what we talk about in boards in general, which is that you don't want everybody leaving and everybody coming at the same time. So our next steps in all of this work is create opportunities to test and assess the broad acceptability of these recommendations. This is something I've been thinking about quite a lot. We do these mini public deliberations, but how is there a way to test and see whether a broader public would accept those recommendations? We are really interested in developing this process for ongoing public involvement. And we continue to discuss the role and process of evaluation. As Mhairi noted in the consensus statement, we recognize that's important. How to do that in these kinds of cases is a little bit more challenging to figure out. And with that, let's say thank you very much. I would really much rather be there with you in person, but it's great to have this opportunity to speak to you today. And now I'm going to pass it over to Felicity and Annette.
Thanks, Kim. And hopefully Annette's going to share her screen. Thanks, Annette. So Annette and I are going to talk about an arguably even more specific example. And we have been looking at sharing government health data with private industry. So just to give you a bit of background into why we started to think we needed to look at this question. I work for the Population Health Research Network in Australia, which is a national data linkage infrastructure network that enables linkage both within and between Australian jurisdictions. And our funder is the Australian Commonwealth Government, and one of the things that they're increasingly asking us to do is to demonstrate the impact of the research that is done with the infrastructure that we support. And that is not just as far as they want to know how many publications have been written, but it's a much broader impact that they're looking for, including on the economy. And they sometimes use words like innovation, and which sort of indicates their interest in commercialization. So there is somewhat of a pressure on us to engage with private industry, and for this kind of infrastructure research to be used for innovation and therefore some kinds of commercialization, which means that we needed to start to consider how we might collaborate and partner with private industry. And in our case, we're thinking about pharmaceutical and device industries, probably mostly. So up until now, really, linked data in Australia is routinely provided to academic researchers, but private industry has rarely had access. So what we wanted to do was to look at what was the best way to work with private industry to meet both the expectations of our funders, but also of the Australian community. So the question that we asked was, what is the public interest in, the community attitudes towards, and the social license for use of linked administrative data by private sector organisations for therapeutic development? And so we entered into a partnership with Achieve at the University of Wollongong. And over the last year, probably nearly 2 years now, we've run a national survey and a series of citizen juries. So Annette's going to talk to you a bit about the work that we've done to answer this very important question. Thanks, Annette.
So I'm going to talk both about the survey that we ran last year in May and June, and also about the citizens' juries and compare them for us. So we ran a national Australian survey using a convenience opt-in panel from a market research company back last year with a sample size of just over 2,500. We had a nationally representative sample on age, gender and location. And it was a very short survey on the issue of sharing government health data with the private sector. And you could do it in about 10 minutes. There was a short preamble that told participants about what health data was, what we meant by the private sector, and in a couple of sentences, the kinds of issues that might arise. And then we asked people their views on sharing their government health information if all of the personal information had been removed, but sharing that with the private sector. And we wanted to know to what extent they agreed with doing that for various purposes, their views about consent, what mattered to them when sharing information, and then their views about the private sector. Now I'm going to ask you to hold that, and now I'm going to talk about the juries, and I'm going to come back and do the comparison between the two in a minute. So we ran 2 citizens' juries on exactly the same question at the beginning of this year, and you'll see that we got in by the skin of our teeth. It was just before things closed down. We recruited our panels through a social marketing company from their own online panels, and we stratified our participants according to age, gender, education, household income, employment status, with the same sort of aim in mind as Kim described earlier, to create a diverse group of people who represented the Australian population broadly. We gave them a quite extensive information booklet, about 40 pages long, that they received before the juries started. And then we met on a Friday night for dinner, and then on a Saturday, which was mainly information provision and questioning experts, and a Sunday, which was a full day of deliberation. And the question that we asked them to consider was, under what circumstances is it permissible for governments to share health data with private industry for research and development? So 2 juries with some very wholesome looking people there. who arrived at remarkably similar conclusions without any contact with each other. Our Wollongong jury decided that they were fully in support of sharing data with private industries for research and development, but they had 19 conditions that they placed on that final decision. The Parramatta jury were almost unanimous. They had one juror who did not agree, and the others all supported sharing data with private industry. And they had 14 conditions, and those suites of conditions were very similar across the two juries. So the kinds of things were actually quite similar again to what Kim was talking about before. The jurors placed conditions on who could get access to data, what sorts of aspects of private industries and in what ways, what form data could be shared in, and that was always de-identified and in some cases aggregated only. Both juries independently said that it was important to have an independent oversight body that was established to evaluate, to decide what could go ahead, and then to monitor the conduct of research and the use of data by the private sector. They had views about what sorts of purposes data could be shared for, a range of conditions that related to protections and penalties if the private sector companies didn't do the right thing, and views about how much the private sector should be charged for access to public data. Sets of ideas about how to inform the public more generally and the need for that to happen and for transparency to be available, and then views about the extent to which consent was required. So these are just a couple of snapshots of views that came from the jurors. So as I said before, both juries wanted an independent body to make decisions about who should have access to data, what sort of data and under what circumstances, and they would have auditing and monitoring powers. So they were operating really in effect on behalf of the Australian community. They also had quite strong views about the need for there to be penalties for directors and for companies that did the wrong thing. And they were both financial penalties, although we're in a range of views about how big those penalties should be, but particularly public shaming. They wanted companies that did the wrong thing to be in the public eye and to be recognised for that. One of the most interesting things that I think we were able to do was we gave exactly the same survey that we'd given to our national survey participants the year before to our jurors. We did it the first time before the jury started, but after they'd got their information booklet, and the second time at the end of the jury. So as I mentioned before, when we ran the national survey, we asked to what extent do you agree with government sharing your health information with private companies for those three purposes: for research, so that they could develop new medical devices or drug or pharmaceuticals, or to improve health services. And as you can see there, in the national survey, the participants were pretty equivocal. We had just over half of them saying that they thought that that was reasonable. They either strongly agreed or agreed. The jurors, they'd had their information booklets, were generally rather more in support of sharing health information with the private sector, even before the jury began. So they were sitting at about 2/3 to 3/4 at that point. After the jury, they were all way up above 90%. So I think it gives you a picture of what happens in an instance of no information, some information, and then a strong deliberative process. We did the same thing asking about consent. So in our national survey, we asked our participants, what sort of consent do you think you would need to provide to use your health information and to have that available to the private sector? And as you can see here, just over half of those participants said that they wanted to be able to opt in, to be able to decide for themselves whether their information should be used. And then the other versions of don't use my data at all, opt out is okay, or I just use it, I don't need to know, were about equally divided. And we had a small group who weren't sure. Before the jury began, we had a bigger group who thought you needed to be able to opt in. and then small groups under around 10% who said don't use it or opt out or I don't need to know about it, and that same small number who didn't know. After the jury finished, the consent preferences shifted remarkably, I think. So we shifted to a picture where about a third was saying, yes, I still want to be able to opt in, even though as a consensus statement, they basically said they didn't really need that. Another third who said opt out is fine. And then about the same group who said, just use it, I don't need to know about it. There was no longer a don't know group. And we had a very small group at that point who said, don't use my information. So if we're thinking about ways of engaging the public, using this as an example when looking at community views on sharing government health data with the private sector, if all we do is run surveys to find out what people think, well, what we found was really equivocal support amongst what probably was a relatively uninformed population. If we give people information, the level of support for sharing government health data with the private sector went up. If we gave them information and an opportunity to deliberate, then it became quite strong support once they had both the provision of information and engagement. So that's achieved the Australian Centre for Health Engagement, Evidence and Values and our team, Population Health Research Network, and also David Rader from the University of South Australia. I think that now takes us on to the audience participation component of the evening. So I'm going to hand back to Felicity and take us on to our first question.
Okay, thanks, Annette. So I'm actually going to launch a poll so that hopefully all of you can vote and we can do a little bit of public deliberation. I'll give you a few seconds for everybody to respond. Looks like everybody can see the poll, so that's good. The numbers are still changing, so. Okay, I think that's probably about enough time. Should we? I'll end that. And can everybody see those results? I'm not sure if anyone can see it. No? Oh, yes, apparently they have been shared. It's just us, the panelists, that can't see it. But I can tell you that 68% of people said a lack of public understanding or knowledge of current practices. 18% said a lack of institutional understanding or support for public involvement, 12% choosing who to include, and 3% reaching consensus from deliberation. So did any of our panelists want to comment on those results? You'll need to unmute yourselves.
Whose question was it?
That was my question.
It was Vary's.
Well, Vary, you've got to say something then.
Yeah, I think that's a really interesting set of responses, with the majority then going for the public understanding or knowledge of current practices. And I think that's an interesting one. I mean, in part, public engagement is seeking to understand what current understandings are and what current knowledge is, and to find ways of reflecting concerns or preferences in future practice. And in part, it's also about informing that understanding and informing that knowledge. So I suppose that is really at the crux of kind of what this is about, and it's addressing that. Although I would say that from public deliberation that I've been involved in, often we find that there is a kind of, initially people maybe don't feel confident about whether they have adequate knowledge on these topics, but when we engage people in deliberation, we typically find that they're very competent and very enthusiastic to engage in discussions of these topics. So I think the perception of maybe a lack of, I guess there's different kinds of understanding. There might be perhaps not high levels of knowledge of current practices or current kind of institutional arrangements of what happens, but there's often a good understanding of what that kind of means, or what the key issues, particularly when we're thinking about acceptability or ethical issues or social implications of how this data might be used. And I think there's a good understanding of those aspects, which is often what we're trying to explore through deliberation. The second most frequently chosen answer there was a lack of institutional understanding, and that for me is what I think is really crucial to developing good quality public engagement or impactful public engagement. As I said in the consensus statement, our first principle was that public engagement requires institutional buy-in. For me, I think that is absolutely the heart of if we're going to achieve really impactful public engagement or realize the value of public engagement, it needs institutional understanding. Often we have institutional commitments to facilitate public engagement, but it's a commitment to maybe convene a group, but not necessarily a commitment to act on the outcomes or to really understand what value that brings, and to capitalize on the value of the deliberative process. So for me, I think that's the big thing. We need much better institutional understanding and institutional commitments to not just enable these deliberative processes to happen, but to give those deliberative processes impact and to realize the value of that. But interesting responses.
Yes. Annette, did you want to add to that?
No, I'm happy to wait. No.
Happy to wait. Okay, well, let's go on to
I think to add a bit, Felicity.
Yeah, go, Alison.
Yeah. So one thing I want to say is, and this is mostly coming from the perspective of focus groups as opposed to deliberations, but I would make the point that there are some people who are less likely to be able to participate in deliberations because of their life circumstances, if it's, multi-day events. And for sure, I would have picked B as well, because what we found there, for example, when we did focus groups around what ICS does, is people had a really hard time understanding what we were talking about. When we talked about linked health data, many people thought that we were talking about bringing together their own health data to support their own personal care, which was something they actually cared quite a bit about, because in many cases face challenges getting lab test results, for example. So even helping people to understand what we were talking about was challenging. And I would also say that when we move into operationalizing practices where we're actually acting on public advice, I think B is particularly important. And this is part of the point of the notches on the dial article. There's a big difference between, I think basically even the preferences around consent probably vary depending on the circumstances. Clearly for a trial of a drug, people are going to want to give that. There's a certain expectation. This speaks to the social license point too, right? Like people expect hospitals and even private companies to be using the data that they gather. They may not expect to provide consent. And then there's this class of research that works on, population-wide unconsented data. So I'd say B, in my experience, is definitely the biggest challenge. Thanks for the opportunity.
Thanks, Alison. Okay, let's move on to our second poll, which is about sharing health data with the private sector. So go ahead and fill that one in. Give it a couple more seconds and then we'll finish. Okay, I think I'm going to end it there and share those results. Well, that looks like a much more even spread. Can you see those results, Annette?
No, you'll have to read them out.
Okay, so nobody said the private company pays for the use of health information. 17% said the private company is required to publish all results, both good and bad. 24% said there are strict rules to stop the information being passed on to anyone else. And 24% also said there are criminal penalties or heavy fines if companies break the rules. And 34% said the public is told how the private company will use their health information.
Well, I find that really interesting because I've got the benefit of knowing what the national survey found out, which for them, so we asked each of them, how important would this be for you? And the top priorities of that list of 5 were strict rules to stop information being passed on to anyone else. Over 90% said that. And criminal penalties or heavy fines, again, over 90% said that. And then the next 2 were number B and E. So the private company being required to publish results, and that was sitting at about 80%, and the same proportions for public being told. And the one at the bottom, which no one went for here, but which in the survey, just over 60% said they still thought was important, was paying for the use of health information. And when we ran the jurors all thought that the private sector should pay for the use of health information. Now, they didn't think they should pay a lot, so it wasn't, you know, millions of dollars, but I think they came down on the side of thinking, well, this is actually a way in which we can reinvest resources back into the health system. Some wanted to do that. Or they wanted to fund the independent panel with the proceeds of people paying for the use of the health data. But it also spoke to their views about whether the private sector ought to be allowed to make a profit from the use of public data and people's individual health data. And we haven't put that one up here, but the jurors, the national survey, there was a very wide range of and a fair amount of diversity about the extent to which people agreed with that. And the jurors, by the time they finished, were broadly in support of the private sector being able to make a profit. And I think it was because they'd come to see, well, that's what the private sector does. It makes profits from things. And if those things are also in the public benefit, well, then that's okay. So really interesting. I don't know what the other panelists think about this. Yeah.
Nobody wants to jump in. Now, we've got quite a few questions that have come in, and we've only got about 12 minutes left. So I think maybe we'll try and get through and answer some of these questions. People are happy to do that. So one of the most popular questions was, it's a very hard point to meet, but how do you try to ensure that the panels and groups you convene are representative of the population you're trying to get input / assurance from? Who wants to go first?
Do you want to have a go,
Kim.
Kimberly?
Yeah, I'm happy to do that. So I think the answer may be different depending on the type of public engagement that you're doing. In our case, I'll just focus on deliberation. That's what I know best. We really de-emphasize representation. The problem with representation in a deliberation is that you really don't want to recreate the sort of majority viewpoints. What you really try to draw out in a deliberation are, like Alison was hinting at earlier, people who are less likely to be involved, less likely to have a voice, people who have less opportunity, but may have experiences that inform their views on things. So in a sense, we're far more focused on maximizing differences and maximizing diversity to represent all views held in the public rather than trying to create a representative sample. So that's the deliberation approach.
Alison?
I would just say too, I mean, no matter what you do, be aware of circumstances where a general panel or general group is not fit for purpose. So for example, one of the things we wrote about COVID-19, the disproportionate effect on racialized minorities and people that live and work in long-term care homes, don't think you can get advice about COVID-19 data that covers those perspectives without direct engagement and involvement of the affected groups.
Okay, let's move on to another question. Did any of the participants in any of your studies raise the fact that people are very willing to type highly sensitive information into a Google search engine, but then not make similar data available for bona fide purposes that can improve community health?
I think it's popped up in both of the juries that we ran this year. So the privacy paradox is a thing, and the jurors could comment on it. I think because they, at least in our juries, they came to the view that it actually is a good thing to be sharing one's health data. Whether that's partly informed by having decided, well, I'm happy to share the rest of my data, I don't think that's as much the issue as coming to see that there are significant benefits from it. But people are aware of the privacy paradox, but I don't think they quite, I think we sort of shrug our shoulders and say, well, that's it.
We had in several of our studies people who commented along the lines of their health data is special to them. I'd say it's personal information. It's very personal information. It's extremely sensitive information, sensitive conditions. So from that, it seemed that they were okay with searches being mined and things like that, but they wanted health data to be treated in a different way.
I would say that, and then you can imagine after 4 days together, our participants tend to get into issues like this. And I would say that there's a sort of a twin thing here of resignation and expectation. So on the resignation side, I think people fully understand that you're trading personal information for services, and that there is at some level not too much you can do with a private sector company if you want the service from them. If you want to do a Google search, this is just what's going to happen. On the other hand, when we're talking particularly about the public sector, there's an expectation that that public sector is working on your behalf and that you have a say. And so the standards are just completely different, I think, in what the public both understands is happening and expects to be happening.
Yes, right. So let's move on to the next question, which is something that I'm really interested in trying to tackle. How do we move beyond engagement with small groups of citizens to developing and maintaining broader public support for data sharing, which can withstand what must be almost inevitable events which will challenge that trust?
So the jurors in our two recent juries actually had recommendations about creating ways in which the broader public could become more aware of the use of data linkage and people's data. And so it was some of it was standard mechanisms of websites and registries and that made information available about usages. Some of it was going back to the focus on situations in which breaches occurred and making sure that they were well publicised, and jurors saying that that actually did quite a lot to ensure that people knew about the use of their data. And to some extent, I think they pushed back a little and said, well, we're going to have an oversight body. They're acting on our behalf, and we can't expect that every time everyone will know all about this. So I think there are two kinds of answers. Quite a long time ago, I did some work looking at a very specific example of data linkage, which was using baby health records and hospital attendances. And those jurors had some very specific ideas about how you got to the affected groups, which was basically everyone who had a baby. So you just made sure that information got into what we then called the baby blue book, which was the book that you carried around that had all your baby's vaccinations and measurements in it. So I think one of the things that these kinds of small groups can be quite good at is coming up with ideas about how to help everyone else understand, because they are really very good representatives of the everyone else. So,
anyone else want to tackle that one? Mhairi?
Yeah, so I mean, I think it is a really big challenge in this area, and that often these kind of deliberative processes, public engagement events, are often relatively small groups, and one of the main strengths is the depth of understanding and the depth of discussion, and that's how we can really understand the nuances of public positions and the reasons that those positions shift and change, and what are the kinds of factors influencing public responses, and that's what's really valuable in those processes, but it's also what makes it really hard to scale up, because as you get bigger, you lose the depth, and the depth is really the valuable thing there. There are there's a lot of experimentation and deliberative methods and kind of larger scale deliberative events and processes, citizens assemblies, which are we're seeing increasingly often. I think one of the big challenges there is that it's kind of the experience of the process that leads to the understanding of the outcome, or the legitimacy or the value of the outcome. And actually, maybe partly what we need is greater understanding and raising awareness of those processes and what those processes look like and how outcomes are reached. And again, that's challenging, but how do we, maybe increase publicity or awareness of those processes and experiences of those processes? But the other side of it, I think, when we're talking about if this is about generating public trust, there can be a tendency to think that this is maybe then through these processes we are identifying the messages we need to convey to ensure public trust in the institutions or in the data practices and arrangements. But the other side of that is that actually through this we're identifying what it means to be trustworthy, and what's really crucial is that we demonstrate that we're acting on the outcomes or the recommendations of these processes, and demonstrating why certain things are changing or certain decisions are being made, say around governance or around access or uses of data, and how those decisions have been based on and informed by the views and values of the public, and thereby demonstrating trustworthiness rather than emphasizing communicating messages that are going to be trusted, which is a different thing. And so I think it's partly about scaling up the processes, but it's at least as equally importantly about demonstrating that those processes are leading to meaningful impacts and are influencing and shaping future practices.
Thanks, Mhairi.
So if I can, Felicity, can you just, I mean, a very small thing, which is I think what we need to start doing is trying to experiment with different modalities and different methods. So for example, if we do a good public deliberation and we have a set of recommendations, if there's really important decisions to be made, we could take that to the recommendations from that small group to the public and ask if they are willing to endorse their fellow their fellow residents' positions on these things. So I don't know if that's the perfect answer, but I think we need to kind of combine these things as a way to scale.
Sure. Thanks, Kim. Now we've only got 2 minutes left. It would be almost remiss of us not to mention COVID-19 in a session of this conference. There's one question about whether public attitudes to data sharing have changed as a result of COVID. If anybody's got a 30-second answer to that. No, Kim?
My sense is that the public is willing to give public health in particular a break here and share more, but under very strict understanding that it's temporary, that this is not a permanent change. And I think that the experience with contact tracing apps is what underlines that there isn't a wholesale just like do what you want, but I think there is more willingness temporarily.
I'd echo that, and I guess say that at least in Australia, levels of trust in government in a public health area are higher, so therefore willingness to share is probably higher as well.
Okay, and that I think it's time for us to wrap up. So thank you so much to all of the panelists today, to Annette, to Alison, to Kim and Mhairi, and particularly to Alison and Kim for staying up into the wee small hours to share their amazing expertise with you. Thank you also to the audience who were fabulous in asking lots of questions and filling out the polls. And we hope that you enjoyed the session, and tell your friends it's recorded, and I'm sure anybody else can watch it tomorrow. Thank you, everybody.